Hello, this is Dr. Amin Marashi, retina specialist in Marashi Eye Clinic in Aleppo, Syria. I am presenting the course of OCT for macular diseases. In the previous presentation, I discussed the structure changes in the outer retinal and choroidal tissue. In this presentation, I will discuss vitreous and inner retinal layers reflectivity changes. In cases of intravitreal large floating floaters that cast a shadow on the retina, the shadow will appear as hyperreflectivity of retinal tissue causing shadow artifact, as shown in this OCT cross-section. Another finding that is causing shadow artifact in this OCT cross-section is the hyporefelectivity of retinal tissue underneath the major blood vessels, which is a normal finding in spectral domain OCT. Increased reflectivity of the vitreous in the form of hyperreflective dots may be found in vitreous hemorrhage and vitritis, as in this case of proliferative diabetic retinopathy with vitreous hemorrhage, as the heme appears as hyperreflective dots. However, the hyperreflective lines are artifacts from intravitreal hemorrhage located more anteriorly. This cross-section shows fibrovascular proliferation causing traction on the optic disc along with residual vitreomacular traction with cystic formation and increased central macular thickness. In contrast, this OCT cross-section shows hyperreflective dots in the vitreous resembling inflammatory cells from vitritis due to Behçet disease, along with corrugation and increased reflectivity of retinal tissue, as the former feature is due to the proliferation of the epiretinal membrane, while the latter feature is due to ischemic changes due to vasculitis. Another feature of this cross-section is increased retinal thickness and subretinal fluids. When hemorrhage is located in the subhyaloid space, the hemorrhage will appear as a homogeneous hyperreflective accumulation of blood with smooth borders between the posterior cortical hyaloid and the ILM. Hemorrhage usually casts a shadow artifact, which appears as hyperreflectivity of the underlying retinal tissue, as shown on this OCT cross-section. This OCT cross-section of proliferative diabetic retinopathy with central diabetic macular edema shows increased central macular thickness and intraretinal cysts. In contrast, the sub-ILM hemorrhage will appear as homogeneous hyperreflective incarceration of blood with a smooth border between the ILM and inner retinal tissue causing its displacement. The retinal tissue underlying sub-ILM hemorrhage may appear hyporeflective due to shadow artifact caused by the sub-ILM hemorrhage. The sub-ILM hemorrhage is due to the rupture of perifoveal capillaries caused by rapid changes in intraocular venous pressure, thus can be caused in the Valsalva maneuver, sneezing, or coughing. However, other reasons for sub-ILM hemorrhage could be blood dyscrasia. Cotton wool spots are shown to increase the thickness of the retinal nerve fiber layer due to ischemic changes causing accumulation of exoplasmic material within the nerve fiber layer. As in hemorrhage, they cast shadow artifact causing hyperreflectivity of the underlying retinal tissue and are differentiated from sub-ILM hemorrhage from clinical examination. Cotton wool spots are less likely to be located centrally. They are less uniformly organized as in sub-ILM hemorrhage and less likely to cause indentation or displacement of the rest of the retinal tissue with less effect of shadow artifact. When there is an increased reflectivity of the inner retinal tissue, especially when the involved layers are up to the outer retinal plexiform or outer nuclear layer, there is an ischemic retinal vascular process. As in this OCT cross-section of central retinal artery occlusion, there is an increased reflectivity of inner retinal tissue up to outer retinal plexiform layer, with increased thickness of these layers. This is due to the retinal artery reaching the inner nuclear layer, causing ischemic changes to the inner nuclear layer and other inner retinal layers. If there is a doubt about the status of the increased reflectivity, then OCT cross-section can be evaluated using negative black and white, as increased hyperreflectivity tissue will appear as increased shades of black. However, OCT shouldn't be used as a solo ancillary test to diagnose retinal artery occlusion. Fluorescein angiography and OCT angiography may be a better diagnostic tool as they study perfusion and not as OCT, which studies only structural changes. Therefore, macular edema related to retinal vein occlusion, there would be increased hyperreflectivity of inner retinal tissue, along with increased central macular thickness, with intraretinal cystic changes and intraretinal hemorrhage, with or without subretinal fluids, as presented in this case of OCT cross-section of macular edema related to branch retinal vein occlusion. Please note the difference of inner retinal tissue reflectivity between the involved half of the occlusion and the spared half. Thank you for listening. I hope you find this information useful in your daily clinical practice. Please stay tuned for the next presentation, where I will discuss other hyperreflective changes in outer retinal layers and choroid in the OCT of macular diseases.